Hear, hear. Hear, hear. Hear, hear. Parkinson's Podcast. Welcome to the Hear, Hear Parkinson's Podcast, where you will hear from special guests covering the world of Parkinson's with a deep dive on the World Parkinson Congress and a look at how the WPC has helped make extraordinary progress in the Parkinson's community by creating space for people with Parkinson's to have a seat at the table.
Hear, 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 hear. We are back with another fresh new episode of the Hear, Hear podcast, leading us all up to meeting each other face-to-face in Phoenix, Arizona, May 2026. I am Edgar Valdmanis. I'm one of 16 global ambassadors for the Congress spreading the happy news. And I do have the pleasure of frequently making a new podcast with senior people that are definitely going to Phoenix. I'm looking forward to that. And chatting with these people beforehand so that more and more will say, hey, this is the place I need to be a year from now. Today, we have our special guest, Dr. Per Borghammer from the Aarhus University. And if you think I pronounced that quite clearly, it is, yes, because it is in Scandinavia. I am myself placed in Oslo, Norway. Per Borghammer is in Aarhus University in Denmark, which is just a good stone's throw from my home. So welcome in, Per.
Thank you very much. I'm very happy to be here.
Good, good. How's life these days? Challenging?
Yeah, no, it's going pretty well, I have to say. Today, right now, it's raining, but that's more or less a normal situation in Denmark. So no, I have no complaints.
Good, good. If we start out with your studies, you have done quite a lot of research on, let's say, the difference between the brain and the gut. I have a Parkinson's diagnosis myself, and I understand from your research that you've studied the fact that a number of people with Parkinson's get the first symptoms in the gut, and then it goes up towards the brain, whereas a number of others start out in the brain, and then it's the symptoms show up in the gut. And then over time, they sort of merge. Could you expand a little on that? Because this is really interesting.
Yes, thank you very much. I'd be happy to discuss that a little bit. So, in fact, I think we should start by saying that in 20 years ago, the so-called Bragg hypothesis was proposed by Professor Heiko Bragg from Germany. And that hypothesis was a revolution in the sense that he proposed that Parkinson's disease always starts in the gut, you could say, and then spreads upstairs from there, hitting the bottom of the brain first and then moving up. He also said that it simultaneously starts in the nose, in the olfactory bulb, but it doesn't really spread anywhere from there. Okay, so basically what he said back then was it always starts in the gut and then goes up from there. So what we have been doing the last 10 years is basically to expand on that idea, because it became obvious quite quickly that Professor Bragg's idea was probably not the full explanation, since for many different reasons, and there were many different types of data that suggested that, but I suppose we can get back to that. But anyway, so what we are saying now is, with this hypothesis, is that it definitely seems to be true that a good fraction of people with Parkinson's, the pathology probably started in the gut, probably more than 20 years before the patient actually gets the diagnosis of Parkinson's. So it starts in the gut, moves through the nerves that connect the central nervous system to the gut. So it kind of invades the brain, you could say. It enters at the bottom of the brainstem and then goes up and up from there. So this is what we call body first. And the body first type of patients, they get these bodily symptoms first. So constipation can be seen 10, 20 years before diagnosis. Problems with the urinary function, problems with the blood pressure, that it can be low, the patients can be dizzy and so on, perhaps even faint. And then once the pathology is inside the brain, it reaches the middle part of the brainstem first, you could say, and there it affects some circuitry in the brain that is used for sleep, you could say. So once this circuitry is affected, some patients start to develop REM sleep behavior disorder. And again, that typically happens 5-10 years before diagnosis in body first. REM sleep behavior disorder is this, I think it's well known to most of the audience, but you act out your dreams while you are sleeping. You can shout, you can move your arms and legs, perhaps fall out of bed. And this is it's not supposed to be like that. When in a normal sleep, you're supposed to lie still when you're dreaming. So all of this happens before the diagnosis. And then eventually, once the pathology has reached the top of the brainstem, that is where the dopamine cells are located, these starts to be damaged. And it probably takes around 5, 6, 7 years before enough damage has accumulated in the dopamine system for the Parkinson symptoms to start to emerge, so the motor symptoms. So that's kind of the trajectory and the time course in body first.
But to me, it sounds like as a person with Parkinson's, I can't really do very much about it. A number of people say, well, if I had been diagnosed earlier, I could have gotten medicine earlier and I could have been better off. But I postponed going to see when others said, hey, Edgar, you should go see the doctor because you're shaking or trembling or you're tripping over on the sidewalk, falling, whatever. And then every time I said, no, it's just nothing. That is very common that people delay going to the doctor. But what you're saying now, I couldn't really go earlier because no one would recognize the symptoms earlier. Is that correct?
Well, I mean, yes and no, I guess.
I mean, a slight constipation. So the doctor says you should drink more or you should eat more grain.
Yeah. I understand exactly what you mean. So, okay, so on the one hand, constipation, and perhaps you could say urinary problems and so on, these types of symptoms are quite common in the population. So that means if a random person starts to develop constipation, it's probably not because of Parkinson's disease, because there's 100 different reasons for constipation. So
exactly.
And that's completely true. That is not the case for the REM sleep behavior disorder symptom. That is actually quite specific. So it means that if a person is seen by an expert that knows about this sleep disorder, asks the right questions and so on, and eventually if you get the sleep examination, that's called a polysomnography, if such a diagnosis is made, it's actually very, very specific for Parkinson's disease. Then we know with a very high probability that it is actually very early Parkinson's disease that this patient has. But if I may so everything as you said, Edgar, still to this day, I think, most common people, so to speak, in the street, they don't know enough about Parkinson's. They don't know that constipation can be a Parkinson's symptom and so on. But I guess the future we are moving into, where as soon as we have a drug that can actually stop the progression, or stop or at least halt the progression, slow down the progression of Parkinson's disease, then we need to find the people, the patients, as early as possible. We would like to find them 5, 10, 15 years before the diagnosis, because if we can stop the disease there, then, well, it goes without saying that then the patient would be, the person would be able to live a life without getting all of the really nasty symptoms of Parkinson's disease. So in that sense, it's also a matter of educating the population and the general practitioners, the doctors, and so on, preparing them for the future that we hope will be here soon, where we have a drug that can stop the disease. Once we have it, we need to be able to find the patients very, very early. So at that time, people need to know that constipation, for instance, can actually be a very early sign of Parkinson's.
Right. So what do we do to get to that point?
So do you mean the point of educating the? Yeah. Well, I mean, I think it's honestly, at the current moment, since we don't have this drug yet, it's often said, well, then, and even many of the patients say, I wouldn't want to know that I have this disease before I finally get the diagnosis, because it would ruin my life. And that's true. At least it's, we're all different people, and we, some people want to know these things beforehand, and some people absolutely don't want to know these things beforehand. And that's completely fine. However, that situation completely changes overnight once we have a drug that can actually do something about it. So I would say, so what we're doing as researchers right now is we're preparing for the future where we have this drug. So number one, we need to develop the tools, blood samples, and perhaps stool samples, these kinds of things, so we can find the patients. We need to be able to do that. And then we also need to prepare for educating the population and educating the general practitioners and so on, such that they can, so everybody will understand that it's important to screen the population for these diseases, because we can actually do something about it. It's exactly the same thing as many other diseases, like cancer. Certain cancer diseases, we like bowel cancer. You give a stool sample to your GP, and if he detects blood in it, well, then you will have a colonoscopy, because if you have a very early cancer, perhaps you can be cured. So that's a completely normal thing in medicine, and the population, I think, understands that this is a good idea. And I think once we have that drug in Parkinson's, it'll be the same thing.
Right. As I said in the introduction, you are at Aarhus University in Denmark. How many other universities have, we're talking global then, how many others have people like you studying Parkinson's based on these gut symptoms?
Well, I don't know, honestly. No, I mean, I can't give you an actual number, but there are many groups all over the world that are focusing on this, and I would say that it's becoming more and more common, that more and more researchers are paying attention to this very early, these early symptoms like constipation or the sleep disorder and so on.
Are we talking 10 or 20 or 114, or if you were to give it a guess?
I really can't say, but it's probably at least 100 groups, I would say, worldwide that to a certain extent is is using this thinking in their research.
That is a lot, though. I wasn't aware that we were that high in numbers, but then there should be. Logically thinking as a layman, I would say then someone should find this drug in the foreseeable future. Or is it that hard actually to land on a drug?
Yeah, I mean, the question of a drug that can stop the disease or initially just slow down the progression. I mean, there's definitely, I mean, many groups, more than 100, hundreds of groups, and also the pharmaceutical companies are working on this problem. So, because it is obviously the holy grail, you could say, in Parkinson's disease, it is to develop a treatment that can actually slow down the disease. So, but it is incredibly hard, and the pharmaceutical industry and researchers have been working on the problem for decades. Many molecules have been tried, both also in clinical trials of humans, and they have all failed so far.
Right. And, so it's actually like winning the lottery.
Yeah, I don't know, but hopefully not. Because the lottery is pure luck. Hopefully, this is also. I think our chance as a field, our chance of getting to that drug will become better and better because we know more and more.
Yeah.
You could say the main reason for all those previous drugs having failed is simply that we didn't understand the disease well enough. Because as soon as we really understand the core concept of what is Parkinson's disease, then surely we'll be in a much better place to actually develop a drug that does something about it.
Yeah.
And in that sense, I think even in the last 20 years where I've really been part of the field, I mean, what we know now and the way we think about the disease is almost, it has changed so much even over the last 20 years. So I'm actually quite optimistic that the chances of getting to that drug is better and better for every year, you could say.
Right. Changing the focus a little, we're having this podcast series in order to start warming up for the next global congress in Phoenix, Arizona in May 2026. So it's like closing in on just a year from now. Are you planning on going to Phoenix?
Yes, absolutely. I certainly hope so. That I'll be attending along with some of my group members.
Good. What do you find as being the best part of these? How many congresses have you been to so far?
I've been to two WPCs, yes.
Right. What is that, the Kyoto one and the Barcelona then?
Exactly, yes.
Yes. What did you find the most exciting or educational or fun or?
Well, I mean, it's really a mix of two things. So on the one hand, I think the WPC is a unique conference in the sense that it's also a conference for the people with Parkinson's disease. So the patients or the people with Parkinson's disease are there. So there's a large focus on the patient perspective. Also, like these patient-focused sessions on can be therapy, it can be rehabilitation and these sorts of things. And you meet the patients in the hallway and at the posters and talk to them. And I think that's very unique for WPC, and it's not the case in the other conferences. So on the one hand, that's the unique aspect of the conference. on the other hand, at the same time, it's a high quality scientific conference. So the quality of the scientific sessions is at a very, very high level. And I think that's very important because it needs to be at the highest level to attract the best researchers and their groups to promote that discussion. And as a matter of fact, I think that the last, the 2 WPCs I have attended has been some of my favorite conferences, also with regards to the scientific level of the discussion. It's actually been higher than in some of the other conferences I have attended, which is only science and not the patient perspective. And so I think the WPC has managed to actually do both things at the same time.
I'm so glad to hear. As you may notice, I just sat very still and thought, just let him promote it. Let him promote. There is also another aspect. To which extent did you meet new people that you didn't know from before? I mean,
Yes.
how many, again, not an exact figure, but was it like a good handful of new colleagues, new networks that you could build on?
Absolutely, yeah. I have a couple of ongoing scientific collaborations with research groups where we have met each other at the WPC conference in Kyoto. So yes.
That is fantastic. Do you know Swedish Sara Riggare?
I'm not sure, actually.
All right, then you're one of 2 people that do not know her. I'm just kidding. She seems to know and be known for large groups of people going to the WPC, and otherwise she's quite a figure. A couple of weeks back, she said to Eli and myself, she said, I go for the science and I stay for the community.
Yeah, that seems to be a very nice way of summarizing what the WPC is about.
Good. Then we'll give that another shout out for Sarah. If you then, or when you go to Phoenix and you see this Swedish lady, red hair and a walker, you know what we in Norwegian call a rullator, walker. That's her, and you should definitely go up and say, hey, everyone else says I need to speak to you, Sarah. So here I am.
Yes, I will. I promise.
Good. I think we're getting towards the end of this podcast, unless you want to add something yourself. We have a couple of what we call exit questions, but we do have time if there is still something you want to add.
Well, yeah. Maybe just briefly, because when we discussed initially, Edgar, we ended up discussing kind of only about the body first type of the disease, and that led to the discussion we had. So I think it's important to. I would like to emphasize just a few words about the what we call the brain first type, namely.
Absolutely.
Yeah. So it seems like. I think, I'm quite convinced that a fraction of Parkinson, and it's actually probably more than half of Parkinson patients that develop the so-called brain first type. And this type of disease is probably started in most cases via the nose. So the olfactory bulb, that's the nerve in your nose that you smell with, so to speak. So that the pathology invades that nerve via the nose and then gets inside the brain. So this route of spreading is faster because there's actually just a short way to the dopamine system from using that route. That means these patients are younger, when they get the diagnosis. And when they get when the Parkinson symptoms starts and they get the diagnosis, by that time the pathology has still not managed to spread very far downstairs. So these patients do not have REM sleep behavior disorder yet. Mainly they don't have constipation and they don't have blood pressure problems to nearly the same extent. But they tend to develop it over the next 10 to 20 years because the pathology then spreads in the other direction. So that's the difference between brain and body first and clinically. And the reason for why I'm bringing it up here is to say that so far we have been in the field, we have been very, very preoccupied with studying the body first type. And that's mainly, and that's because it's been the easiest, because as I explained, this REM sleep behavior symptom, it's very recognizable and we can diagnose it. So that means we can actually find body first patients 5-10 years before diagnosis because of the sleep problem. However, we cannot, it's really, really difficult to find brain first patients 5-10 years before diagnosis because they don't have these recognizable symptoms that we can learn to identify. In fact, they don't really have any symptoms to speak of, it seems. So in my opinion, this group have been a little bit neglected before diagnosis. I mean, studying brain first before diagnosis, because we have been so preoccupied with studying body first. And right. I think, and as I said, coming back to that punchline, once we get that drug, we want to give it to every Parkinson patient before diagnosis. But then we'll be faced with the problem that we can't find the brain first patients before diagnosis. So we really need, I think that's something we really need to start focusing on. How do we find them? Is it in a blood test or a skin sample, or how do we find them? Because the patient can't tell us themselves because they don't have any symptoms that we can latch onto. So I just wanted to put that out there and say that's something I would really encourage my colleagues to go into a little bit more in the future.
But these patients then do have a lack of smell as a symptom, but that is the only one. And as you say, it's not connected to anything else. It's lack of smell.
Some of them do, but it's a dangerous question that you put there, Edgar, because it could lead to a very long answer, and I don't think we should go there. But I just want to say one thing. It's actually curious that body first patients also develop more loss of sense of smell than the brain first patients, even though in the brain first patients it actually comes in via the nose. And I have a very long hypothesis explanation for that, but I think perhaps it's beyond the scope of this podcast. But we know that that's a fact. We know it from the clinical cases that that's a fact. Brain first patients have slightly more intact sense of smell than the body first patients. So not even there can we find them robustly.
Right. So there are still challenging times ahead.
Yes, absolutely.
Right.
We are making progress, I would say, all the time.
Yes. I just wanted to extend shortly on that. When you say it comes in through the nose, I would translate that as being through the what do you call that? The breathing system, breathing, whether it's through your mouth or your nose. I enjoyed the book that came out a few years ago called Ending Parkinson's Disease.
Oh, yes.
The 4 co-authors are pretty strong on the fact that, or the fact according to them, that what do we call it, poisons in the air or water or earth are
Yes,
a major factor in developing Parkinson's. Do you have
absolutely.
any comment on that?
Yeah, I do, and in fact, I share their concerns and their viewpoints. In fact, I even just last year I wrote a review paper along with Ray Dorsey. He's one of the co-authors
Yeah.
of Ending, and a very strong proponent for the idea that many cases of Parkinson's disease are caused by the environment, by
Yes.
pesticides and other toxins that we
Yes, that
interact.
was the word I was looking for, the environmental.
Yes. Okay. Yeah. But I agree on that. I mean, it's not. It has not been definitively proven. It has to be said. But I think that there's a lot of it's a little bit like a detective story. There's enough evidence lying around the crime scene here that we need to take it very, very seriously. And I think that evidence is strongly pointing towards that the environment is responsible for causing a very large fraction of Parkinson cases. So I agree on that. Just to say one thing, coming back to the brain first, body first idea, in effect, you could say the gut first versus the nose first, because that is actually what it means.
Yeah.
And it's so, and that's very curious because the nose, the epithelium, that you have inside your nose, and the lining in your gut, that are surface barriers towards the outside world, both of them.
Right.
And it's very curious that it seems like Parkinson's actually starts at the surface of our bodies. So what starts it? It has to be something that comes from the outside. At least that seems like the most logical explanation. So I think that's completely probable that it is mostly an environmental disease.
Right. Pollution was the word I was looking for earlier when I ended up with poisons in the air.
Yeah, right.
But pollution is a poison. So we're definitely coming to an end here. Apart from the two exit questions, which are kind of personal. The first one is that your ship has sunk and you are washed on shore on a deserted island. There's you and this one palm tree, and it so happens there is a record player lying in the sand, solar powered, so that's solved. There are no records, and you sit and think, if I could play only one record on this record player, what would it be? Any musical genre,
one piece of music.
classic.
Oh, that's a difficult question, Edgar. But if I had to choose one, I could choose Beethoven's Ninth Symphony.
Okay, that's dramatic.
Yeah, I know it's dramatic, but it's a very long piece of music and it's really good. So if I own one piece, I would choose one which is an hour long and not just a 3-minute long pop song.
Right. The second and absolutely final question is, you're in an elevator stuck between two floors. Who do you want to be stuck with?
Oh, my wife.
And you're totally free in time and space, living, dead.
Okay. Well, I mean, I have to say my wife would be the first pick. Otherwise, I'll be in trouble. But my second pick would be somebody like Einstein or Newton or Darwin.
Because?
No, because these are some of the thinkers that have had the most, in my opinion at least, the most profound influence on our understanding of the world. So I would be curious to have a conversation with them and just pick their brains on how they see the world.
Good. Well, that sums up today's edition of Here, Here, our podcast leading to Phoenix, Arizona. I thank you, Per Borghammer from Aarhus in Denmark, for being with us. And it certainly was very educational for me. So thanks a lot and have a good day onwards.
Thank you for joining the Here, Here Parkinson's podcast. If you would like to experience the next World Parkinson Congress for yourself, to feel and see the change in real time, save the date to join us from May 24th to the 27th, 2026 in Phoenix, Arizona. Learn more at WPC2026.org. This podcast series is made possible with support from Blue Rock Therapeutics.